Good afternoon. Welcome to Facebook live from CGH Medical Center. This is Dr. Bill Bird. I'm Chief Medical Officer here at CGH. It's June 22nd. Thank you so much for taking the time to join, whether that's live or sometime later. Today we're going to talk neurology and some neurology diagnoses and common problems and medications and how to manage those problems with some new medications. And also we're going to talk about teleneurology because the doctor I'm going to have on is actually a teleneurologist. So without further ado, let's kick this interview off and get Dr. Kay Wynn on. Hi, Dr. Wynn.
Hi. Hi, Dr. Bird.
Thank you for taking the time to join me. And for those who, so we're going to get into, like I said, this is not just talking about neurology. This is talking a little bit for folks who might be interested about teleneurology, which is what you do. And so it's going to be a little different interview. But before we even get into it, just so folks understand, Dr. Wynn actually works for a company that we hire to provide services for us. So she's on our medical staff at CGH, but she works remotely and works for a company that provides those services. So maybe we could start, Dr. Wynn, with just tell the folks who are watching a little bit about yourself.
Sure. So I'm a general neurologist with a subspecialty in clinical neurophysiology, which mainly focuses on peripheral nerves and seizures. So that's my subspecialty. So I actually started out my training. I grew up in Texas, so all of my training was in Texas. And then I actually had a private practice clinic on site as a general neurologist.
Okay.
So due to family reasons, I had to move to California, not by choice because of my husband. But anyways, I've been in California for the past 10 years. So after I've moved here, I transitioned to teleneurology. So I've actually been doing a lot of, so I have over a decade of experience in telemedicine, teleneurology. And I did a lot of inpatient work with another company, mainly with telestroke. But as I had said earlier, my background is more of a clinical general neurologist. I really missed the clinical setting. So then I transitioned over to this other telemedicine company that allows me to do CGH clinic teleneuro. So I'm very excited and very passionate about it, because with my experience as a general neurologist coupled with my telemedicine, I feel that at times, I feel like I am the in-person neurologist, and I am helping patients get seen faster and helping them with their treatment, feeling better rather than having to wait months and months for an in-person or on-site neurologist.
Yeah, it's really interesting. I'm surprised when you say 10 years. I mean, I've heard, telemedicine has been, you must have been pretty close to when things got going with telemedicine.
Yes. Yeah.
Yeah. It makes sense that you were doing the hospital stuff first because that was, I think hospitals started doing that before clinics did. I think the clinics, it's relatively new, like for us to be doing this across the country. Is that fair to say that?
Yes, that is fair. Telemedicine started out as a telestroke and then evolved into telerounding. And then now it's the clinic. And now it's kind of like spread to other subspecialties like endocrinology, rheumatology, dermatology.
Right. Which we have, for those folks who are watching, we actually, through the company that you work with, we actually do have dermatology that we utilize here. And also Dr. Friedman, your colleague at Amplify, does inpatient. And I think you do a little bit of inpatient neurology for us too, don't you?
Yes, I do.
Yeah. So, okay, good. So let's talk a little bit keep talking a little bit more about telemedicine. So Kay, can you kind of talk through, for the folks who are watching, how do you make that experience as much like seeing someone in their office, flesh and blood, as possible?
So the key is to make it personalized. So I have to have establish a rapport with the patient. So it's very difficult to do that remotely. So then I have to have a good nurse. So Nathan is my person to go to, because he helps establish that transition for the initial discomfort or uncomfort. So he kind of explains the process to the patient before the patient goes into the room. And then I, of course, have to establish that trust by taking the time to listen to the patient. So with teleneurology versus an on-site, I actually spend more time listening to the patient and answering questions. So I make sure before they leave, all of their questions are answered. So I think that really helps to establish that rapport and trust. And not only that, when I other than spending the extra time, I also show them. I do a screen share. So I show them their actual images, like any imaging order
Okay.
I've
Yeah.
done. So that a picture is worth 1,000 words, right? So that
Yeah.
immediately established that trust moving forward after the second visit. And then I also do a screen share to go over each of their test results. And then I explain in detail what medications, you know, that I will be prescribing. And I even lay out a long-term plan. This is what we do, et cetera, et cetera. So with each visit, I spend that extra 10, 15 minutes to make sure patients understand exactly what's going on. And then also Nathan is very good, and all the staff along with Nathan has been very good at answering all the questions after refilling meds. So it's very critical to have an excellent staff along with to help me with the clinic. So it's a collaborative approach. So that's how I make the teleneural experience feel
So yeah.
reasonable to the patient.
So speaking of screenshots, here's a screenshot of of Dr. Nguyen, and there's Nathan straight in front of us there, her nurse, and then a patient receiving care there through the Tele-Neurology portal. So just to give folks kind of a sense of how that's set up in the room even. So yeah, that's really good to see that. So thanks. Good. So yeah, I mean, I think that's interesting too, that like you're remotely looking at imaging. We can send images remotely. That's all on the computer, labs, all those kind of things. When you see a patient, what used to be something that you'd have a piece of paper that you would look at, you don't have to do that anymore.
Another thing I want to point out is, since I can't really, lay my hands on the patient, I find ways, right, different ways to evaluate the patient. So observation is key. And then Nathan, being a very good nurse, he can help facilitate the exam to pick up subtle differences in tone, muscle weakness. For example, I can even test subtle weaknesses by observing like manual dexterity, right?
Mm-hmm.
Like I don't even need to like have the patient do the hand grip. Nathan, of course, does that for me, but I can test for subtle changes, having the patient stand up from the chair, having the patient walk, or jumping on their walking on their toes, their heels. And I've even had patients do video recordings for me. Like if they say, oh, I have, my walk is this, blah, 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 like they say, oh, I'm falling a lot, or I'm walking strange, or I have a twitching here, or a spasm there. So I say, you know what, since I can't see it during this evaluation, I'm going to have you record it and send it to me. So I'm always thinking outside of the box to try to see what they're telling me. So I think I offer that additional layer of observation and thinking outside the box that makes it the whole process very pleasant to the patient, because the patient is understanding that I'm thinking outside the box and I'm really trying to help them. And so I'm not limited by not being there in person, is what I'm trying to say.
I guess I would ask, I mean, I guess it's worth asking the question. Speaking of limited, are there any particular neurological problems that you would tend to say, hey, let's have someone who can examine you in person see you?
So far, no. Amazingly, I think with my years of experience, I've been able to get a good history and good help with the exam from Nathan, and with the diagnostic. I think I can pretty much see everything. And as you can tell from my clinic, I've seen a variety of neuromuscular cases, movement disorder, MS. So actually, the answer is no. There are no neurological conditions that I feel uncomfortable diagnosing remotely.
Yeah, and we were talking before we went on the air, and you used Dr. Dela Cruz, one of our neurologists that's here, to do like something called an EMG, which is a nerve conduction test. So you have ways of getting those things done. Good. So let's talk about, now that we've kind of talked the telemedicine stuff. If anyone has any questions, obviously, please feel free to send those to us while we're talking. But I want to move on into let's talk about some different neurological problems that you work with patients, and pick your brain a little bit on those. So Alzheimer's continues to be an issue in the news, an issue with the advancing age of our population, and more diagnoses are made. And there's a lot of emphasis on early diagnosis of that. What's the latest, any latest developments in terms of ways to get an earlier diagnosis of Alzheimer's disease, Dr. Nguyen?
Yes, so Alzheimer's disease, so the newest medication out there is called the Leqembi. So it's an IV infusion. So the key is to catch the diagnosis early. So as soon as the families, typically the family, sometimes the patient will notice subtle memory loss. So if we go in, and so you have to refer to the neurologist as soon as possible. So after the evaluation, you would have to be in the mild cognitive impairment range. And we can easily determine that by the bedside testing that we do during the evaluation. After we confirm the diagnosis that it's mild, then we would have to do further testing to see if it is the Alzheimer's component, because oftentimes in dementia, there's an overlap. There are different types of dementia. So there's the Alzheimer's component, and then there's the vascular component, and then there may be the atypical dementia. So there's 100 different things that cause dementia. But for these newer medication, the IV Leqembi is specific for Alzheimer's. So in order to really nail down that diagnosis, the patient would have to undergo spinal tap to look for specific spinal CSF.
Okay.
Certain CSF, and then you would also have to do a PET or a SPECT to evaluate for hypometabolism. So it's a very in-depth workup to really nail down the diagnosis, to make certain that it is Alzheimer's rather than vascular dementia or frontotemporal. Right. So when you confirm that it is early onset Alzheimer's, or even the mild cognitive impairment due to Alzheimer's, not due to anything else, then you would qualify for that medication. And so it's very in-depth workup. At this time, I usually do not do that here. I typically refer out for that because it is an in-depth workup that requires a little bit more time for evaluation.
Okay. So, it's always like this new medicine that Dr. Nguyen's talking about. For those of you who are watching, just the FDA just approved this just recently, if I'm correct. And I think I saw some numbers that it actually is supposed to be helpful in terms of maybe reversing some of the symptoms, a certain percentage of people, but it's really expensive. Was I seeing maybe $6,600 a year or something like that for a treatment course? And I'm assuming that, is it a one-time thing, or is it every year that you'd receive that, Dr.
It's an infusion. So it's an infusion. Is an infusion every 2 weeks. Insurance, as far as I know, will not cover it, and I do not think Medicare covers it.
Yeah, so that's going to be the big rub about that one. That medication is just who's going to pay for it, basically. So the older medicines that have been out there for a while, the Namendas of the world and those kind of things. would you still, in light of this FDA medication, would you still consider those others the ones that you would use first?
Yes, for me personally, I always go with the conservative treatment with the traditional meds because I feel like the newer medication, although the results look great, but it does carry significant side effects, which I've explained to the patient, to a lot of my patients. The main side effects are that it can cause brain edema or swelling, and it can cause hemorrhage. So you have to consider the pros and cons of starting the new medication because there is that risk. I usually go with the traditional meds because it's been proven to help kind of stabilize the dementia. And I always stress the importance of conservative treatment with just simple cognitive training, like exercising the brain by doing word puzzles, doing simple math computations, watching Jeopardy, and physical exercise, believe it or not, as studies have shown, actually slows down the progression. And last but not least, your diet is actually very important. Certain foods rich in flavanol will also help with memory. So for me personally, I still use the traditional meds. And if the patients want that new medication, then I would refer out because again, that medication requires extensive testing.
Yeah, if I remember, if I've had this right, it's I don't know how I'm not going to pronounce it probably right, but lecanemab, is that the?
Yeah,
And
yeah,
I'm going to spell it
yeah.
for folks just in case you might be interested. Lecanemab. So for folks who are watching who might be interested in just kind of looking that up. Okay, good. Okay, let's stay on the new medicine conversation. Let's talk migraines. So can you talk a little bit about, there are some new migraine medicines that fall in some classes called monoclonal antibodies, gepants, and I'm going to call them ditins or ditins.
Ditins, yeah.
Yeah. Tell us more about all that, because once again, this is kind of a new frontier in terms of migraine treatment.
So migraine is very, very interesting. Migraines have been around for a long time. So I believe migraines are kind of like a channelopathy disease. So with the newer medication, so how I approach a migraine patient is.
One more time, when you say it, what kind of myopathy?
Channelopathy. So that's why certain, the traditional medications, they target certain channels. That's why it works, because it's actually a channelopathy. That's why the migraines are episodic. They come and go, come and go. So that's why some of the certain traditional medications work. So I want to explain how I usually approach a migraine patient. So migraines, there's two ways. It's during the acute phase. So patients get confused. They think, oh, well, if I take an ibuprofen, that should take care of my headache. But migraines are a little bit more complicated in that you have to treat it during the acute phase. Like right when you have a migraine, you need to take a medication to abort it. And then there's the preventative, where you got to take the medication every day to break the cycle. So once I explain the difference in treatment, then my migraine patients understand it. So with the newer medications, there is the monoclonal antibodies that target specifically the calcitonin receptor protein. That's a protein that is by blocking that protein, that specific protein in your brain, it prevents you from having the headache. It's a migraine or a headache prophylaxis. So all these monoclonal antibodies like the Aimovig, Ajovy, they all break that cycle to prevent you from having the migraine. The gepants, the GEPANTS, and the dietins, those are used for the abortive. And so the gepants also target the calcitonin gene related peptide, but it's a different molecule. It's a smaller molecule versus an monoclonal antibody. So just think of it as a different structures. Each medication has different structures. And so they target the CRGP, but it's just a different structure, and it's used either as an abortive treatment or as a preventative treatment. So to keep it simple for you.
Okay. And we're talking like smooth muscle receptors. So like
Yes.
as the muscles kind of contract and expand. So that's what you're talking about,
Yes.
to keep that from being quite as significant for
Correct.
patients. Okay. That's good to know. So I know I've read enough to know that those drugs aren't necessarily cheap either. Can you kind of talk about that and where insurance is at with some of those medications these days?
Yes. So insurance is this is what I tell all my patients. Insurance will not approve any of these newer medications unless you have failed at least 2 to 3 traditional medications.
Okay.
Because the cost is just very expensive and no one can burden the cost. So insurance does not want to pay for it. So they do require that we try 2 to 3 medications, and they have to fail the medications, the preventative ones.
Right. And like when we say traditional medications, I nowadays like Imitrex or some of those kind of medicines would fall into that category, if I understand it correctly.
Correct.
Yeah.
So the triptans are the abortive treatment. So the insurance will cover that. The traditional medication, so there's the abortive and then there's the preventative. So the preventative ones, there's a lot of good preventative medications, and those medications work just as well as the newer medications, and it's been around a lot longer. And so we usually try that, and most of my patients respond to the traditional medications, and a few have gone on to the newer ones, but those are few and far in between.
Yeah. Okay, that makes sense. And yeah, I mean, the reason I guess you would try those others just because from a cost standpoint and because they work. So,
yeah.
Okay, good. I see a question here. It's about caffeine and migraines. You want to talk about that?
Yeah. So caffeine. So basically, when you have so caffeine does help when you have an acute headache. So we do use that when you have an acute severe headache. But if you take the caffeine too much on a daily basis, then what will happen is your body will get used to it. Then you develop a rebound component. So yes, you can take the caffeine, but in moderation. You limit it. You don't want to take it a lot where your body gets used to it. Then you go on to develop a rebound headache, and then it becomes a vicious cycle that you can't break.
So for like your patients that have really bad migraines, are you good with them having a cup of coffee in the morning?
Yes.
Okay, so that's not an issue.
No, I do that myself. I take one every day, and then I try to limit that caffeine afterwards, even if I have a headache.
Yeah, I normally do, but I think I'm gonna have some caffeine this afternoon. But yeah, I hear you. Okay, Parkinson's disease. I bet you see a decent number of patients with that in your clinic. So what's the latest in terms of any new treatments that are available for that, for those patients?
So the Parkinson's is usually the same. The standard treatment is levodopa, carbidopa. And so there are different formulations. Some of it can be through nasal, some of it through patch, but it's still the same principle. You have to use the dopamine to boost it up. Is a dopaminergic medication in whatever form you choose. The most common is the oral.
Yeah.
And so we use that because Parkinson is a neurodegenerative change. So basically you lack the dopamine. So you're just trying to increase it. And when you have advanced Parkinson's, then we go on to use more of the ancillary medication to help boost up. It works in synergistic with the Cinemet and the this carbidopa. So carbidopa, levodopa. The latest the latest development I saw was stem cell research, stem cell therapy for Parkinson's. Okay. But I'm not sure where we are in terms of that. Right now, I still use the medication to help with the Parkinson's.
Yeah, so it's not mainstream. So the idea of some of these stem cell treatments, I've been reading about some of these actually surgeries that they implant stuff to try to stimulate that center in your brain. Still not in the mainstream. Correct. Is what I'm hearing.
And we've used some ultrasound radio, MRI or ultrasound guided to target the basal ganglia to help with the tremor. But again, it's not mainstream, and there's a high risk when you involve any type of surgical procedure. So I usually don't recommend it unless you have really bad tremors, but typically we just go with the medications.
Okay, very good. And then you mentioned that seizures is one of the areas you must have done some extra training on.
Oh, yes.
So I want to ask you a seizure question before I let you go. And talk about medications, diet, or other options that you suggest to try to prevent patients from having seizures.
So typically, lifestyle modification is very important in patient with seizures. Number one is the diet. You want to avoid any foods that's processed. You want to eat natural foods, and you want to take in simple glucose. You don't want to take in like extra complicated sugars like artificial sweeteners. So diet is very important. Number two is you want to do the high protein and vegetable type of diet. And last but not least, I want to stress the importance of, other than diet, you have to have a regular sleep schedule. So a lot of it has to be lifestyle modification in terms of diet, sleep, maintaining a regular schedule, and minimizing stress to prevent breakthrough seizures, other than taking medication.
Yeah, talk a little bit about that diet part of that. So what's the theory behind why these processed foods? And when you say processed, I take it you mean like stuff that comes out of boxes.
Yeah.
Or that is, yeah. Okay. Tell us a little bit more what you've read about why that would be.
So I guess the thing is, it must be because of the certain the processing food. It may trigger. I'm not quite sure as well. It may trigger for you. It may lower the seizure threshold, so that you're more prone to getting the seizures. So I guess there must be something in there, because I'm not quite sure as well. But there is something in there that lowers that threshold to make you have the breakthrough seizures.
Okay. And I've heard some folks talk about being on a
ketogenic.
Yeah, ketogenic, a very high fat, proteiny kind of diet. Can you talk about that and what your feelings are on that?
So usually I only recommend ketogenic diet if the seizures are intractable, like very difficult to treat. I actually recommend the modified Atkins diet, where you don't restrict the calorie, but you increase that protein and the fat to help. It's a minor variation of the extreme ketogenic diet. So it's called the modified Atkins diet, if you want to look that up.
Okay, good. Good. Well, hey, Dr. Nguyen, we're out of time. I appreciate your time, and I appreciate taking the time to talk with me about some of these things that you know about very well. And really great to have you here taking care of our patients. And for patients who are interested or have some sort of neurological problem, of course, we have Dr. Joseph and Dr. Dela Cruz, but we also have Dr. Nguyen that you could see for those conditions. So anything else you would want to say before I let you go, Dr. Nguyen?
No, well, thank you for having me. It's been a wonderful time. Thank you for listening.
Well, I'm all ears as far as this stuff goes, because you're the expert on this stuff. So thank you very much. Great having you, and maybe we'll have you back again sometime.
Okay, sounds good. Thank you.
Thanks. Bye.
Bye.
Great. Well, that was good to talk to Dr. Nguyen on two fronts, both the telemedicine front as well as neurology. So I have some shout outs I wanted to do before we wrap things up, and I know Rebecca is going to tee those up. So first of all, congratulations to a couple people. Don Hartman retired after 32 years working here at CGH, working in the cardiology lab most recently. So Don, congratulations. And Lori Sheridan. So Lori is a case manager and population health nurse, and she was down in the ED a lot, helping out with situations down there as well. So Lori worked for us for over 23 years. So Lori, thank you for your time, and wish both of you the best in retirement. And then I wanted to plug July 13th, we're going to have Dr. Blasquez with us. And Dr. Blasquez is going to talk about diabetes medicines and weight loss. I feel like this is going to be kind of a hot topic, because I'm guessing that some of you are definitely reading about these newer weight loss medications and some controversy about them and how they work for diabetes. So Dr. Dela Cruz is going to talk about all that stuff next time when we get together on July 13th. So once again, I think I'm going to sign out. Thanks for taking the time to watch. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thanks for joining me, and I will see you back July 13th.